In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLLLLS. In a world where knowledge is power, the Academy of Emergency Sciences
Good morning and welcome to the Resuscitation Essentials for Moonlighters, or R.E.M webinar. We want everyone to have the best learning experience possible, so please observe the following guidelines during the lecture. First, please keep your microphones on mute. Second, you are invited to type in your questions in the chat box at any time or ask them live at the end of the lecture. Lastly, the attendance link will only be posted in the chat box at the end of the webinar. A pleasant morning once again and enjoy today's lecture. Good morning and welcome to the Resuscitation Essentials for Moonlighters lecture.
Good morning, ladies and gentlemen, esteemed colleagues, and young doctors. Greetings and welcome to our distinguished webinar series, R.E.M, Resuscitation Essentials for Moonlighters, a tribute to the decade of excellence at the Academy of Emergency Sciences. As an accredited American Heart Association training partner for BLS, ACLS, and PALS, we have consistently upheld the belief that resuscitation is not merely a task, it is our unwavering calling. Our motto, "Resuscitation is our calling, education our passion," underscores our enduring commitment to the art of life-saving. The choice of the acronym R.E.M for this webinar is not by chance. It reflects a profound connection with scientific research, suggesting that R.E.M sleep is when we most effectively consolidate learning and memory. Today, we gather to deepen your knowledge and enhance your resuscitation skills, with the firm belief that the wisdom imparted here will translate into lives saved. This year-long webinar series is generously offered free of charge, our humble contribution to advancing the realm of resuscitation education. We are resolute in our mission to empower young doctors and healthcare professionals with the essential knowledge required for their arduous moonlighting shifts. We express our profound gratitude for your presence here today, and we invite you to embark on this journey of enlightenment with us. Together, let us strive for excellence and remember, resuscitation is our calling, education our passion. It is with great anticipation that we look forward to collectively advancing our understanding and proficiency in resuscitation. Good morning, ladies and gentlemen, esteemed colleagues.
A pleasant morning for everyone. It's an honor for me to introduce our speaker for this month's R.E.M webinar series. Our speaker is a specialist in emergency medicine with an impressive academic and professional background. She completed her BS in Public Health at the University of the Philippines, Manila, and earned her Doctor of Medicine degree from Pamantasan ng Lungsod ng Maynila. She then pursued her residency in emergency medicine at Makati Medical Center, followed by an emergency ultrasound fellowship at St. Luke's Medical Center. Currently, she serves as a consultant at Makati Medical Center and is also an instructor for BLS and ACLS at the Academy of Emergency Sciences. And now, without further ado, let's all welcome Dr. Moira Madel Manyala. Doc, the virtual floor is now yours.
Hi everyone. So I'll be sharing my screen. Kindly let me know if you can see it. There. Can everybody see my screen? Ma'am Dessa, can you see my screen?
Yes, Doc.
Okay, yes. And then audio is fine?
Yes po.
Okay. So good morning. So I am Dr. Manyalak and I'll be giving this lecture for today. So the lecture is entitled STEMimics, STEMI equivalents in the ER. So the objectives of my lecture is to define ST elevation myocardial infarction, or STEMI, as we all know, discuss the paradigm shift to occlusion myocardial infarction versus non-occlusion myocardial infarction, or in short, OMI versus OMI, briefly discuss the significance of early detection and management of your OMI, a brief review of the electrocardiogram, and to explore the different STEMI equivalents found in the emergency department. So according to the Philippine Statistics Authority, data from January to August 2023 showed that ischemic heart disease was the leading cause of death in the Philippines, with 76,901 cases, or a total of 19.1 total deaths in the country. So this is similar to the statistics back in 2022. So for the first objective, now let us define what an ST elevation myocardial infarction is. So ST elevation myocardial infarction, or STEMI in short, is the most severe clinical condition that falls under the umbrella of acute coronary syndrome, or ACS. No? So ACS encompasses conditions characterized by a sudden decrease in myocardial perfusion. So a decrease in the perfusion occurs when the blood supply to the heart is partially or completely occluded by a clot, leading to oxygen depletion and subsequent death of the myocardium if it's not treated early. So the condition is reflected on your electrocardiogram, or your ECG, showing ST elevation on specific leads depending on which region of the heart has decreased perfusion. And it follows certain criteria set forth by your AHA or ACC. So your STEMI is a clinical syndrome involving myocardial ischemia, ECG changes, and your chest pain. So this is the STEMI criteria according to your American College of Cardiology and American Heart Association. This was the 2013 STEMI criteria. So it's very specific. So for men less than 40 years old, you should have an ST elevation of more than or equal to 2.5 millimeters in V2 or V3, or greater than 1 millimeter in any other leads. In men greater than 40 years, the ST elevation should be more than 2 millimeters in V2 or V3, or more than 1 millimeter in any other leads. And they also specified it for women, but for women, it's regardless of age. The ST elevation should be more than or equal to 1.5 millimeter in your V2 or V3, or greater than 1 millimeter in any other leads. So this is just the commonly taught STEMI criteria for us, no? Ever since, even when I was in med school, this is the criteria that we followed. So the following slides will show examples of your typical ST elevation MI. So this is the ECG of a 38-year-old man who presented with chest pain, nausea, and diaphoresis, no? So we can see, as emphasized by the arrows, that there are ST elevation on your leads 2, 3 AVF, corresponding to the inferior wall of the heart, as well as beginning ST elevation on your V5 and V6. You can also see reciprocal changes. So that's your ST depressions in your V2 to V4. So this ECG is equivalent to your inferolateral MI. So this is another ECG. It's an ECG of a 43-year-old man who was reporting 8 hours of left chest pain with arm pain. So give time to review the ECG. So we can see ST elevation on your leads 1 and AVL, as well as your V5 and V6, with reciprocal changes in your leads 3 and AVF, as well as your V2 and V3. So this corresponds to your lateral wall myocardial infarction. This is the slide, ECG of a 57-year-old man with chest pressure, dyspnea, and nausea. So we can see ST elevation in your 2, leads 3, and AVF, as well as your V5, no, and beginning in your V6. So this again is your inferior and lateral wall MI. So for your inferior wall MI, which is usually seen in your represented in your leads 2, 3, and AVF, some inferior wall MI are associated with your right ventricular MI. So right ventricular MI is when you see ST depression on your leads V2 here. And when you see an inferior MI, ST elevation in your 2, 3, and AVF with ST depression on your V2, you should request for your right-sided leads because the infarct in your inferior and lateral wall might extend to the right side of the heart. So we can see that here in the next slide. So this is the ECG of the same patient, but with right-sided precordial leads. So when we say right-sided precordial leads, the leads that were placed in your V4 to V6 is transferred to the right side of the heart, right side of the chest with the same location, but it's representing the right side of the heart. So we can see ST elevation in your V4, V5, or V6, or more appropriately labeled as your RV4, RV5, and RV6. So when you have ST elevation in your right side, V4, V5, V6, this is equivalent to the presence of your right ventricular MI. Okay. So those are just some of the examples of your typical ST elevation myocardial infarction. This next slide differentiates what we call a benign early repolarization, or BER, from an ST elevation caused by your myocardial infarction. So your non-AMI is seen here in the left side, and then your AMI upsloping is seen on the right side. And then the bottom image shows the differentiation between the ST elevation from your benign early repolarization and your acute myocardial infarction ST elevation. So to discuss this further, these are some examples of your ECGs which show benign early repolarization, or BER. So characteristics of your benign early repolarization, to differentiate it from the STEMI from myocardial infarction, because in truth, it's very difficult to differentiate both, one from the other. Some characteristics are that one, of course, there is an elevation at the J point. So can you see my arrow ahead? Can everyone see the arrowhead? Okay. So this arrowhead, no, these are the elevation at the J point. So some characteristics of your BER is that there is an elevation in the J point, which is why it makes it confusing if it's either STEMI or a BER. You have the T wave that is peaked and slightly asymmetrical. When we say peaked and asymmetrical, the upsloping is concave, and then the descending limb is steep and straight. And then also one other characteristic of the upsloping of your ST from your benign early repolarization is that the shape of the ST sloping is concave or a smiley face. So that's your T wave, peak T wave. This slide emphasizes the elevation at the J point, marked by the horizontal line. The arrows point to the notching of the J point. And the arc or the curved line shows the concave or the smiley upward slope of your ST elevation from your benign early repolarization. So it's like sagging downwards. It's a smiley shape ST elevation. This next image shows the difference between the upward sloping of your ST segment from your benign early repolarization versus your acute myocardial infarction. So the upwardly concave slope is from your benign early repolarization, and then the upwardly concave is the one that is more common in your acute myocardial infarction. Okay. So one technique that you can use if you're not sure is to draw a diagonal line from the J point there to the apex of the T wave. And if the slope falls below the diagonal line, that's usually your concave, no, sagging. And if your slope falls on the top of the diagonal line, that's a convex morphology, and that's usually more commonly seen in your acute myocardial infarction. So this slide emphasizes the J notching in your benign early repolarization. Okay. All right, so let's go to the next topic, which is the paradigm shift, from your STEMI versus NSTEMI to OMI versus OMI. So we've all been kind of trained to define your ACS based on the presence or absence of your STEMI. Your acute coronary syndrome was previously labeled as it encompasses your STEMI. If there's no ST elevation, then it's NSTEMI. And then if there's no changes in your biomarkers, then it's an unstable angina. So that's what we were taught way back. And actually, majority of the students that I've dealt with recently still have this mentality, no? But there has been studies that have found that the overall sensitivity of your STEMI criteria in detecting coronary occlusion has been put into question. So, di ba, we want to identify STEMI and then proceed to activating the cath lab because we're taught that only STEMI patients require urgent reperfusion. When actually, from the past researches, patients who fall under the NSTEMI criteria, meaning that their ECGs they don't complete the criteria of the STEMI based from the ACC or AHA, they were also found to have occlusion in their coronary arteries. However, it's just that they had delayed reperfusion because of this paradigm that we are strictly following now. STEMI lang ang cardiac catheterization. So, the overall sensitivity of the STEMI criteria was found to be put into question. It's not as sensitive as they thought previously. And that there's studies done in 2024 that the sensitivity of your STEMI in identifying coronary occlusion is actually just 43%, meaning that half, no, were missed coronary occlusions. So OMI stands for your occlusion myocardial infarction, and your NOMI is your non-occlusion myocardial infarction. So again, there were recent updates regarding the shift, no, from the paradigm of STEMI versus NSTEMI to OMI versus OMI in the detection of coronary occlusion. So it resulted from the many NSTEMI patients with unrecognized coronary occlusion who do not receive emergency reperfusion, leading to increased mortality. So since and STEMI, yung ECG, no STEMI was seen, but they were presenting with chest pain, diaphoresis, no? They did not undergo emergent reperfusion, but later on, due to persistent pain and chest pain, they did undergo reperfusion, and that was the only time that occlusion was found with the angiogram. So it led to the delayed reperfusion. So over the years, ECG findings that don't fulfill the ST elevation criteria have been identified as having a strong correlation with coronary occlusion. In 2022, AHA and ACC actually released an update on the diagnostic approach of patients presenting with chest pain, and it included in their census were the STEMI equivalent. So they had additional criteria, no, for ECG findings that did not meet the STE criteria but were actually um, advised, no, to have urgent reperfusion. So we want to shift away from asking, is my patient having a STEMI, to, is my patient having an acute coronary occlusion that would benefit from immediate reperfusion? So one of the things that happens kasi with the STEMI paradigm is that our mentality is like boxed into just looking into the ST segment in determining whether our patients have are in need of urgent reperfusion. When actually, when you look at the whole ECG, there are other criteria there that they found that would actually prompt urgent reperfusion. So that's why we want to ask the question, is my patient having an acute coronary occlusion that would benefit from immediate reperfusion? Because we can see other signs in the ECG other than your ST elevation. So why is early detection of occlusion myocardial infarction significant? So there's what they call the golden hour, which is actually 60 minutes, no? That when a patient, 60 minutes when a patient starts to complain of the chest pain, and then you see them, you catch them in the ER, and then they're put into cath lab, it significantly improves the prognosis of the patients, no? And then especially if treatment is initiated within 6 hours of symptom onset. So there's decreased death in your myocardium, and then it leads to reduced mortality rates and development of secondary complications. So some complications of your untreated AMI could lead to heart failure or arrhythmias, and we can prevent these, no, if we initiate treatment early. So how is your occlusion myocardial infarction treated, no? So American College of Cardiology, or ECC, and your American Heart Association, as well as the European Society of Cardiology, recommend that the percutaneous coronary intervention, PCI, is the preferred method of reperfusion. So if the first medical contract to balloon time is less than 90 to 120 minutes. So coronary angioplasty with or without stent placement is the most common method of your coronary intervention, PCI. But if the institution is not capable of your PCI, which is also common here in the Philippines, we have the option of fibrinolytic agents. They act on the acute thrombosis directly or indirectly as clot busters, no? And fibrinolytic therapy is indicated for patients with STEMI if time to treatment is less than 6 to 12 hours. So yung PCI is 90 to 120 minutes. And if you go past that, no, as long as it's less than 6 to 12 hours from symptom onset, you can still give your fibrinolytic agents. And as long as the ECG also has at least 1 millimeter ST elevation in 2 or more contiguous leads. So that's what the AHA, ACC, and the European Society of Cardiology recommends for your fibrinolytic therapy. And then after your PCI or fibrinolytic therapy, you also administer your antiplatelets, anticoagulants, nitrates, beta blockers, and your ACE inhibitors. Okay, so time for the review. So what is an electrocardiogram? So I've been discussing about your ST changes, your T waves, and we might need to review on what I've been talking about so that the latter part of the lecture will be easier to understand. So what is an electrocardiogram or your ECG? So your ECG is a non-invasive diagnostic modality that serves as a recording of the heart's electrical activity on a strip of paper. So it corresponds to the depolarization and repolarization of the heart. It can help in identification of rhythm disturbances, conduction abnormalities, or electrolyte imbalances because these have specific findings in the ECG, but will not be tackled in this lecture. Most common indications for ordering the ECGs are, but are not limited to, patients who present, of course, complaining of chest pain, palpitations, who had an episode of syncope or a dizzy. Sometimes ECG is also indicated for patients with acute onset seizure. ECG also aids in management of shock, cardiopulmonary resuscitation, or metabolic disorders, because as previously said, some metabolic disorders present with specific signs in your ECG. It can also help in monitoring pharmacotherapeutic effects and adverse effects of drugs and anesthesia. So these are some of just a basic overview of ECG. Okay, so a review of your ECG placement. Hopefully we're all aware of where the leads are placed and not just how to read the ECG. So this slide presents the placement of the 10 electrodes that are used in your ECG. So you have 4 limb leads placed in your both upper extremity and both lower extremity. And you have your 6 electrodes that are placed on the chest. So these are your precordial leads. So you have 6 precordial leads placed as shown in the image. And you have your 4 limb leads as shown also in the image. And this is the figure that represents the important components of an ECG. So it consists of small and big boxes, which correspond to the duration. It depends on if you interpret it on the horizontal x-axis or the vertical or y-axis. So each small box corresponds to 1 millimeter or 0.04 seconds. Each big box corresponds to 5 millimeters in terms of height, or 0.2 seconds in terms of your x-axis. Therefore, 5 big boxes or 25 small boxes corresponds to 1 second. So take time to digest this image. So your waves include your P wave, your QRS complex, your T wave, and your U waves. So those are your waves: P, QRS, T, and your U wave. The segments and intervals here are the PR interval, your QRS complex duration, your QT interval, and your ST segment. Okay, so yeah. Okay. So this figure depicts what the different components of your ECG correspond to in the cardiac cycle. So your PR interval depicts your atrial depolarization. Your QRS complex depicts the ventricular depolarization, and your ST segment corresponds to your ventricular repolarization. So activation and depot with your repolarization. So the P wave, now let's just go over all the waves quickly. So the P wave, the one shown in the green box, is the first component of a normal ECG waveform. It's the first positive deflection. It denotes the atrial depolarization. And the presence of your P wave means that the conduction of the heart originated from the SA node, which is found in the left atrium. So the presence of P wave preceding each QRS complex denotes a sinus rhythm. So when you say actually that the ECG is sinus, that means that there is the presence of a P wave preceding each QRS complex, and that the conduction of the heart, electrical conduction of the heart, was originated from the SE mode. Going to your PR interval. So the PR interval reflects the impulse from the atria through the AV node and the bundle of His, and then through the right and left bundle branches. So the normal duration of your PR interval is 0.12 to 0.20 seconds. So by box, that's 3 to 5 small boxes. So it starts from the beginning of the P wave to the beginning of the QRS. So this is your PR interval. And we count the small box in between to determine the duration. The QRS complex is the complex that follows the PR interval after the P wave. It represents the depolarization of the ventricles, which is followed by a myocardial contraction or a pulse. The Q wave is the first negative deflection after the P wave. So mentioned before, P wave is the first positive deflection in your normal ECG. And then in your QRS complex, the first negative deflection is your Q wave. It is followed by the R wave, which is the first positive deflection. And then the S wave is the second negative deflection of the QRS complex. So we're just talking about the QRS complex. So the Q is the first negative deflection, the R wave is the first positive deflection, and then the S wave, the second negative deflection following your R wave. So the normal duration of your QRS complex is 0.06 to 0.10, which is usually 3 to 5 small boxes. So next is the J point. So this is very important to understand because the um, determination of your ST elevation, depression, it is based on the J point. So the J point marks the end of the QRS complex, meaning the end of the S wave going up and the beginning of the ST segment. So that's the J point. Your ST segment represents the end of the ventricular conduction or depolarization and the beginning of the ventricular recovery or repolarization. It extends from the S wave, end of the S wave, to the beginning of the T wave. So this is your ST segment. So this is the segment that was mostly focused on with the STEMI paradigm, no? So usually isoelectric, meaning horizontal. So any change in the ST segment may indicate myocardial damage. So the T wave is the next wave. So it represents the ventricular repolarization or the relative refractory period of ventricular repolarization, the period during which cells are extra vulnerable to stimuli. So it's usually upright in your 2-3, V3 to V6, and inverted in your AVR. So upright meaning positive deflection. But in your AVR, it's downward, negatively deflected. So tall, peaked, or tented T waves may indicate myocardial injury or hyperkalemia. So sorry for the typo. So that's hyperkalemia. Next interval is your QT interval. So the QT interval measures ventricular depolarization and repolarization. Normal duration is 0.36 to 0.44, depending on the age, sex, and the heart rate. And your U wave is not always present, but it represents the recovery period of the Purkinje or ventricular conduction fibers. So it's not always present on your rhythm sheet. But if you see it, no, it may be due to hypokalemia or hypercalcemia. And it's the wave that follows the T wave and precedes the P wave. Okay, so a quick technique on how to interpret your ECG is what I use from med school. It's R.E.M. So R is for your rate and rhythm. You determine the rate for regular rhythm based on the 1500 method. Rate for irregular rhythm is the 10 times method. The rhythm is based on the presence or the absence of your P wave. So as mentioned before, the presence of your P wave connotes a sinus rhythm, no? And interval between your P2P interval or to R2 interval if it's regular or irregular. Axis is based on the eyeballing of your leads 1 in AVF. Hypertrophy, there are lots of criteria for your hypertrophy based on the chamber RAH, LAH, RVH, LVH, but the most commonly used is the Sokolow line for your LVH. Ischemia or infarct, for ischemia, you would have signs of ST depression, peak T waves, pathologic Q waves, and your infarct would be seen as an ST elevation. And then the M in your rahim is your miscellaneous findings. Those are your duration of intervals, your PRQT intervals, duration of your QRS complex, and if there are any presence of your ectopic beats or rhythm abnormalities. So this is like a quick way of a guide of how you can interpret your ECG so you don't get overwhelmed. Okay. And then this is the last slide for our ECG review. This slide shows the leads corresponding to their walls, the heart walls. So you have your 1 in AVL with your V5 and V6, um, which represents the lateral wall of the heart. Your 2-3 AVF represents the inferior wall of the heart. And then your V1, V2, V3, V4 represents the anterior septal wall of the heart, while your EVR, no, by journals represents the right side of the heart. So they taught us before that when you diagnose STEMI based on the STEMI criteria, is that the ST elevation should be present in at least 2 contiguous leads. When you say contiguous leads, these are the groupings based on their corresponding wall of the heart. So that's either ST elevation on your 2-3 AVF or ST elevation from your V1 to V4, or if there is presence of ST elevation in your V5, V6, or 1 AVL. So these areas, no, represented by your lead groupings still hold for your STEMI equivalents. So let's go to the bulk of the lecture. So what are these STEMI equivalents? No? So STEMI equivalents, as mentioned earlier in the earlier slides, there's been a call for the paradigm shift from identifying patients with coronary artery occlusion from STEMI versus NSTEMI to OMI versus OMI. It was also mentioned that this paradigm shift tries to break away from focusing too much on the ST segment as the only component of the ECG to look into when deciding when patients are in need of urgent reperfusion. So STEMI equivalents, therefore, are signs on the ECG that have been found to represent coronary occlusion without meeting the STE criteria. So the STEMI equivalents, these were found via angiogram findings. So studies were done. They correlated the angiogram findings of patients with occlusion to their ECG findings, and they found that these ECG findings, the ones that will be discussed, are represent coronary occlusion, and although do not meet STEMI criteria, indicates early reperfusion. So in 2022, the ACC expert consensus decision pathway on evaluation and disposition of acute chest pain in the emergency department, it states that STEMI versus NSTEMI dichotomy may miss people with occlusion myocardial infarction. So they said on 2022 that in the absence of ischemic ST segment elevation or your STEMI, the ECG should be examined for other changes that have been associated with coronary artery occlusion. When present, these should prompt evaluation for emergent coronary angiography. So yung STEMI equivalents, it's recognized by your ACC, AHA, and European Society for Cardiology. Okay, so this guideline is also lifted off from the ACC guidelines. So they said that if you see a STEMI in the ECG or a STEMI equivalent, you manage the patient already as per the AHA STEMI guidelines. But if you see ischemic ST segment depression or T wave inversions, ST segment elevation in your AVR with multi-lead ST depression, or your Wellens sign, they can be managed as per the NSTX guideline. But will for this purpose of lecture, all these will be considered as STEMI equivalents. So the STEMI equivalents, the easiest way to remember them is the mnemonic PTSD. So P is for your posterior MI or posterior myocardial infarction. Means your T wave abnormalities, where there are three. S stands for your scarbosis criteria, and your D is for your diffuse ST depression, multi-lead ST depression with ST elevation in your AVR lead. So let's go to the first, PTSD, letter P. P stands for your posterior MI ECG changes. So the posterior MI accompanies about 15 to 20% of STEMI, usually occurring in the context of your inferior or lateral wall MI. So if you see an inferior or lateral wall MI, meaning that the leads involved are 2-3 AVF, 1 AVL or V5, V6, you may check for the presence of your posterior MI. So the posterior MI ECG changes would correspond to these, no? Horizontal ST segment depression in your V1 to V3, dominant R wave in V2. So this is your dominant R wave. Upright T waves in anterior or anterior leads. So your anterior leads would be your V1 to V4. And then there should be an ST elevation of 0.5 millimeters in the one of the posterior leads. Okay. So when we say posterior leads, no, we transfer your V5, V4, V5, V6 leads, no, the ones in the anterior precordial leads, to the posterior part, no, at the back. So the posterior leads are placed in the left posterior axillary line. Same, the V7 is at the posterior axillary line. Your V8 would be at the tip of the left scapula, and then the V9 should be at the left paraspinal region. So these are how you get your posterior leads. So since the posterior extension, the posterior myocardium is not directly visualized in your standard 12-lead ECG. When you see signs of possible posterior MI, which is this, no, ST depressions in your V1 to V3, look for your presence of your posterior MI by requesting for your posterior leads. So this is an ECG of a 75-year-old woman complaining of mid-sternal and backache. So we can see here, ST depression in your leads V1 to V3. Dominant R wave in your V2. So it's a big R wave compared to your S, and compared to your whole QRS complex. You have your upright T wave in the anterior leads. So that's an example of your posterior MI. So this is another ECG of a 56-year-old hypertensive male complaining of chest pain with diaphoresis. So I'll give you time to look at the ECG. So you have the first thing that you can actually see here is if you're used to identifying ST elevation, is that you have your ST elevation in your 2-3 AVF. And then, as previously mentioned, your posterior MI is usually, associated, if not in the inferior wall, you have your lateral wall. But since you have an inferior wall here, let's look for signs of your posterior MI. So again, posterior MI, presence of your horizontal ST depression in your lead V1 to V3. You also have your dominant R wave and the upright T waves in the anterior lead. So since we have your inferior wall, ST elevation here, and then we have signs of your posterior MI based on the ST depression, upright T waves, and dominant R wave, we ask for a posterior lead. So this is the posterior lead of the same patient, no? We see V7, 8, and 9. These are placed on the back, on the scapular area. And we see ST elevation of at least zero point 0.5. So when you see an ST elevation of at least zero point 0.5 in the posterior lead, 7, 8, or 9, then you have confirmed the presence of also a concomitant RV, right ventricular MI. So this is another ECG, a patient, a 72-year-old female complaining of fatigue associated with chest pain and nausea. So here we don't see any ST elevation, but there are horizontal ST depressions in your V2 to V3. You have your dominant R wave in your V2, and then your upright T waves in your anterior leads. And then the posterior ECG of this patient, shows an ST elevation of at least 0.5 millimeter in your V7, V8, V9. So this is a posterior MI. Okay, so this is an actual patient seen in the ER. It's a 93-year-old female complaining of chest pain with shortness of breath. So at close look, no, we can miss this, but there is presence of your horizontal ST depression on your V1 to V3, but in this case, it's just V2, V3. You have your upright T waves in the anterior lead. And when we requested for the posterior leads, there is ST elevation of at least 0.5 in the V7, V8, and V9. So same patient. Okay. So going to the second STEMI equivalent, TT, letter T. So T wave abnormalities, we have three. We have three T wave abnormalities to discuss. The first is the De Winter T waves. So the De Winter T waves was first reported in 2008 by Dutch professor Robert J. De Winter. The characteristics are as follows, no? The pattern, tall, prominent symmetrical T waves in the precordial leads. So this is your tall, prominent symmetrical T waves. Symmetrical meaning the upward and the downward slope is the same. Upsloping ST depression, that means that there is an ST depression first, and then you have an upsloping. Parang concave then, like your BER. And then absence of ST elevation in the precordial leads, and then you may have a reciprocal ST elevation in your AVR. Okay, so that's your tall, prominent T wave. This is the ST segment depression starting from the J point. And then you have your upsloping ST segment, no? So this is an ECG of a 52-year-old male presenting with back pain radiating to the chest. So we can see the tall, prominent symmetrical T waves in your V2 to V4. The upsloping ST depression. So you have your ST depression here. And then the upsloping ST depression. There's no ST elevation in any of the precordial leads. And then you have your ST elevation, no? 0.5, just 0.5 to 1 in your AVR. Okay. This is an ECG of a 70-year-old female complaining of vague abdominal pain with nausea and diaphoresis. So we can see tall, prominent T waves again in your V2, V3, V4. It also extends to your V5, your upsloping ST segment depression, from the J point, and then your reciprocal ST elevation in your ABR. This is an ECG of a 63-year-old male presenting with shortness of breath. Okay, again, we see the prominent T waves, the upsloping ST segment depression from the J point, no ST elevations in the precordial leads, and your STE in your AVR. So actually, the very key characteristic in your De Winter is the upsloping ST depression in your prominent T wave. Okay, so the second T wave abnormality to discuss is the Wellen syndrome. So the Wellen syndrome has two patterns. The first is the biphasic pattern. The biphasic T-wave pattern in the mid-precordial leads. So it was first described in 1982 by Wellens and colleagues as being highly specific for a large proximal left anterior descending artery, LAD obstructive lesion. So you have two patterns, no? This is the deep symmetrical T-wave depression inversion, and then you have your biphasic T-wave. So the Wellens can be both, no? So the pattern A is shown here, no? Biphasic T wave, meaning initial positive deflection and then terminal negative deflection. So pag ganyan siya. It's less common, found in only 25% of cases. Pattern B, though, is more common, 75% of cases, characterized by a deeply inverted symmetrical T wave. May extend from V2 but may to V4 but may extend to V6, no? So sometimes medyo it gets confusing when you identify or label it as pattern A and pattern B. So better to just describe it as a as a biphasic T wave or a deeply inverted symmetrical T wave. So this is pattern A, showing biphasic T wave, initial positive deflection, then terminal negative deflection. Usually in the precordial leads V2 to V4. And this is your pattern B, which is a deep symmetrical T wave inversion. V2 to V4 may extend to V6. So very deep, no? Goes past your S wave. Okay. So this is an ECG of a 57-year-old woman with chest pain, but now pain-free after sublingual nitroglycerin. So we can see the more common of the two, the symmetric deep inverted T wave. So the T wave usually persists even when the patient is in pain-free state. And usually medical treatment is often unsuccessful. Based on studies, stent placement or angioplasty is what is successful for patients presenting with the winter deep T wave inversions. This is a 46-year-old female complaining of upper abdominal pain, back pain with diaphoresis. So we can see the less common pattern here, the biphasic T waves in the mid-precordial leads. So this patient underwent an emergent coronary angiogram and demonstrated 90% occlusion on the proximal LAD. Diba? 90% occlusion, and yet we don't see any ST elevation. It's all based on the T wave morphology. 54-year-old man complaining of chest pain and diaphoresis. So we see here the less common Wellen pattern, which is the biphasic T waves in the anterior leads. But you can also appreciate here, no, T wave inversions on your lateral leads or on your V5, V6, also in your 1AVL. So this patient had 90% also obstruction in the proximal LAD. 48-year-old male complaining of non-rotatory dizziness with nausea. So we see the less common pattern here, the biphasic T waves. "76-year-old male complaining of epigastric pain with diaphoresis." And we see the more common symmetrically inverted T waves. Okay. So moving on to the third T wave abnormality. Remember PTSD, T, and then the T has three T wave abnormalities to examine. No? The third T wave abnormality is your hyperacute T waves. So the hyperacute T waves, the morphology can be variable, but includes broad, asymmetric peak T waves. So T waves are large relative to the QRS, and often the R wave amplitude is reduced, meaning that the T wave becomes taller than your R wave. Serial ECGs are indicated to judge progression to STEMI because actually the hyperacute T waves was found to be one of the earliest signs of coronary artery occlusion. So when you repeat the serial ECGs, no, the hyperacute T wave may transform into different T wave ECG findings based on the progression of the occlusion of the coronaries. So this is comparing your hyperacute T wave of your early acute myocardial infarction from the peak T waves from your hyperkalemia. So it was mentioned before that T wave abnormalities can also be representative of some electrolyte imbalances. And hyperkalemia presents with a peak T wave. But this is the difference on the morphology of the T wave from your MI and your hyperkalemia. So the hyperacute T wave of your early MI has a broad base, asymmetric, meaning that the ascending limb has a different slope than your descending limb. Compare it with your hyperkalemia, has a narrow base and a symmetric structure. So how one of the how they describe also the peak T wave from your hyperkalemia is like it's pinched. You pinched at the bottom and then pataas siya. And then the AMI, the hyperacute T waves from your MI is broad-based and more rounded yung peak ng T wave. Okay. So this is a 45-year-old female complaining of chest pain radiating to the left arm. So we can see a prominent upright T waves. So it's usually in your V2 to V4. So this looks like your your septal anterior MI. So you can see broad-based, asymmetric T wave, medyo rounded peak at the top. 57-year-old male complaining of chest pain and shortness of breath. So we see again your peak T waves. So the T waves are bigger than your R waves, and then broad-based, asymmetric upsloping versus your descending limb. And then here specifically, your T waves here is bigger than your QRS complex, which is up to here. No? So for this patient, the cath lab was activated and showed 99% occlusion of your LAD. And see that there are no ST elevation in this ECG. A 65-year-old female complaining of chest heaviness. So this is the initial ECG of that female. So let's digest this ECG. And then serial ECG showing the same patient, but with ECG changes. No? So you can see that there was development of your T-wave inversions on your 3 and EVF. That wasn't there earlier. And you can also see that there's a beginning of your hyperacute T waves on your 1 and AVL here. So this is the comparison. Initial ECG is on the top, repeat ECG is on the bottom. You can see that the T-wave development of the T-wave inversions in your 3 and AVF, and then the development of the T-wave, no, hyperacute T-wave. The T-wave here in the second ECG is higher than your AVL, than your previous one, also in your AVL. No. There are your changes. There, up close. So this patient was initially admitted as a case of unstable angina, but due to persistent chest heaviness and the changes in the ECG, cath lab was activated and was found to have 95% occlusion of the LAD. Okay. 59-year-old female complaining of chest pain with shortness of breath. This is the initial ECG. Repeat ECG of the same patient, showing your hyperacute T waves, no, in lead V2, taller T waves in your V2 and V3 compared to your initial ECG. So this is a comparison of your initial ECG at the top and then your repeat ECG on the bottom. You can see development of the T waves. So here, the T waves became taller than your R, no? So that's one of the characteristics of your hyperacute T waves. Okay. So remember, no, for your hyperacute T waves, to differentiate it from your peak T waves from your hypokalemia, the T waves, if you have hyperkalemia, is diffuse, seen throughout almost all the leads. It has a narrow base and looks like it's pinched from the bottom up. So narrow base, sharp peak. And of course, it's associated with other signs of hyperkalemia. So always clinically correlate. While the hyperacute T waves from your myocardial infarction are regional, depending on which part of the heart has decreased perfusion, asymmetric, again, with a broad base, rounded peak, and usually becomes larger than your QRS complex. And of course, it's associated with other features of your myocardial infarction. Okay, so the third from the mnemonic, so this is a bit tricky, is your Scarbosis criteria. So remember, PTS. So the S is for your Scarbosis criteria. So some patients have baseline abnormal ECGs that can pose a diagnostic difficulty in terms of identifying signs of myocardial infarction. So in patients with a left bundle branch block or those patients with ventricular paced rhythms or those with pacemakers, no, they have a baseline ECG that make it uh, difficult to diagnose infarction because their ECGs already have ST elevations, but it's normal for them, for their as part of their baseline ECG. Hence, the Scarbosis criteria was established. So your LBBB, ano ba tong LBBB? So the left bundle branch block, no, looks like this one. So the ECG diagnostic criteria for your left bundle branch block, you have your QRS duration of more than 120. That means that it has a wide QRS, no? So this is your QRS complex, it's wide, no? You start at the start, 1, 2, 3, pag more than 3, wide QRS complex na siya. So that's one, no? To determine if may LBB siya. Two, you have dominant S wave in your V1. So this is your V1. So how did we describe the S wave during the ECG review? So the S wave is your second negative deflection in your QRS complex, no? So sometimes, no, you only have your S wave. So this is your negative S wave. So S wave, dominantly S wave. And then the third criteria is a broad monophasic R wave in your lateral leads. So your lateral leads are your 1 EVL and your V5 and V6. So when we say broad monomorphic, parang R lang yung nakikita doon sa QRS complex in those lateral leads, no? And absence of Q waves in the lateral leads. Lateral leads again are your V5, V6 or 1 EVL, and there should be no presence of your Q waves. Again, the Q waves are, as described before, the first negative deflection, no, sa QRS complex. So kung ito ay positive, that's your R, wala siyang preceding negative deflection. So wala siyang Q wave. Okay. So this is an example again of your LBBB. So ito normal to. No, this is a normal ECG of a patient with baseline left bundle branch block. But when you look at it, makita from the V1 to V2 pa lang, actually kahit V4, parang may ST elevation na siya. But it's not it doesn't mean that the patient has coronary occlusion. It's just because it's part of the criteria as for the left bundle branch block. So yung question is, how can we determine if ang patient na ganito ang ECG ay may STL, may MI? Okay? So to identify again no, the criteria for your LBB, you have your wide QRS, wide QRS, wide QRS, dominant S wave in your V1. Okay? You have your monomorphic or monophasic R wave in your lateral leads. So dito sa V5, V6, ito, V6 natin siya makikita, dominant R wave. And then absence of Q wave in your lateral leads. So lateral leads, V5, V6, wala kang negative deflection sa QRS. No? Okay. So the following slides will show examples of your LBBB. This is normal, not your not siya hindi siya ACS. Okay? Before there's a mentality that we're taught that new onset left bundle branch block is equivalent to STEMI. So cath lab agad siya. So actually that was what I was taught before when I entered my residency in emergency medicine. We were taught that if you see a patient, no, and then the ECG shows left bundle branch block as shown in the screen, and new onset siya, treat as STEMI. Ibig sabihin, activate cath lab. But then, one of the criteria there was that it should be new onset. So how many patients do you actually see in the ER that has a record of their old ECG? So it's very difficult to determine new onset ba to or old, because not all patients are aware of what their ECGs are like, even if they've had many ECGs before. Parang hirap i-decide. Makita mo lang to, parang STEMI na siya agad. So, there have been studies no, that have shown that not all LBBB have documented clots based on the angiogram, because they found that LBBB, this ECG finding, is actually a consequence of a more chronic disease entity, not because of an acute clot. Okay? So let's veer away from thinking that pag may nakita tayong LBBB, STEMI na agad siya, cath lab agad. No, okay? We have criteria, which is what we're going to discuss next, that we need to complete, no, to decide if talagang may coronary occlusion yung patient na may LBB. So this is another example of your left bundle branch block. So wide QRS, more than 3 small boxes, dominant S wave in your V1, and then monophasic R wave in your V6, and then you have a notched R wave, no? Parang yung sinasabi nilang RSR pattern. You can also see it here in your 1 and AVL kasi it says, di ba, monophasic R wave in your lateral leads, and your lateral leads include your 1 and AVL. So, meron ka din dyan. Dominant R wave din. Ay, monophasic R wave din. And here. Okay. So, going back to the question, how do we differentiate or how can we identify a STEMI, an OMI patient, occlusion myocardial infarction patient, in a patient with this type of ECG. Eh dito pa lang V2, V3 parang STEMI na siya eh, di ba? Sabi, more than 2, kahit more than 2 millimeter in your V2, V3, eh more than 2 na to. So STEMI na ba siya? No. So that's where the Scarbosa criteria was developed, no, to aid us in identifying no, patients who have OMI but have baseline left bundle branch block or a ventricularly paced rhythm. So this is the original Scarbosa's criteria. This was made around 1996, no? This was the first guideline to help us differentiate or identify patients with OMI in patients with LBBB or ventricular paced rhythm. So sabi sa original Scarbosa's criteria, you need to meet at least three. You need to get at least 3 points, no, and meet the following criteria, so that you can decide na okay, this patient has new onset myocardial infarction. So one of the criteria is the concordant ST depression of more than 1 millimeter in V1 to V3. Okay, to define terms, concordant means same, same to the QRS complex, to the direction of the QRS complex. So when we say concordant ST depression, so this is shown here on the first image, the QRS complex here is negatively deflected. No? So when we say concordant ST depression, the ST depression is pababa din because negatively deflected yung QRS. So concordant ST depression of greater than or equal to 1 millimeter on V1, V2, V3. So going back to the previous slide, no, dapat dito V1, V2, V3. If there is no ST depression pababa dito of greater than 1 millimeter, no, may 1 point na tayo dyan. 3 points na yan. Okay? So pwede na. Pwede na siya consider as new onset MI. Okay? Or a concurrent MI. So that's the first criteria. Another criteria that can be met is discordant ST segment elevation. So discordant meaning opposite direction, no, of greater than 5 millimeters in leads with negative QRS. So they emphasize negative para maging discordant yung ST elevation. Opposite direction of the QRS complex. Okay, discordant ST segment elevation more than 5 millimeter in leads with negative QRS, you get 2 points if you meet this criteria. Okay? Yeah. So pababa in QRS and then no biglang may ST elevation. But this ST elevation should be more than 5 millimeters. So if we go back to the previous ECG, if ito, negative QRS, if the J point here goes up pa, more and meets more than and goes more than 5 millimeters up before siya nag-slope, then that gives us 2 points. Okay? And then the third criteria that can be met is concordant ST segment elevation, same direction, no, with lead of greater than 1 millimeter in leads with a positive QRS complex. So this has a positive QRS complex, no. If there is an ST elevation, no, here, because this is the J point, because you have more than 1 millimeter ST elevation, concordant to the same direction as your QRS, then that's 5 points. No? So pwedeng 1 lang. But as long as you meet 3 points, no, it was originally considered to be equivalent to occlusion myocardial infarction. Okay? So that's the original Scarbosa's criteria. However, no, recent studies by Dr. Smith found that hindi modified the Scarbosa's criteria to make it more sensitive. They found that the second criteria, this discordant ST segment elevation of greater than 5, fixed kasi itong 5 no? It's only about 20 to 30% sensitive. No, when they checked with the angiogram findings. So he modified it to increase the sensitivity and specificity. Same pa rin in terms of the ST segment depression. Same pa rin with the ST segment elevation, the concordant. He just specified that yung ST segment elevation, the one that's discordant, no? should be at least 25% of the preceding wave. So, i-measure na siya and compare it to the preceding S wave. And it should be at least 25%. And then, according to the Smith modified Scarbosa's criteria, there's no point system anymore. Basta merong one of any of the three, ma-meet yung criteria ng one of any of the three, it's already equivalent, no, to your acute to your myocardial occlusion. So to further demonstrate kung ano yung sinabi niya sa number 2, ST segment elevation at J point. So this is your ST segment, no. Look at the image B. ST segment elevation from the J point. So that's 3.5. Okay. And then at least 25% of the preceding S wave. So ito. So at least dapat 1 millimeter yung inakyat niya. At least 1 millimeter yung inakyat niya from the J point. And the height of your ST elevation should be at least 25% than when you compare it to the preceding S wave. So ito, ang ratio niya, 3.5 yung ST elevation. Yung S wave niya from the J point, no, is 10.5. So when you divide 0.33 or 33% of the S wave, yung ST elevation. So this one, mas specific siya, no? Kasi they took into account the proportion of the S waves. Okay? So that's for your Smith modified Scarbosa's criteria. So we want to practice this one, the Smith modified Scarbosa's criteria, because it has higher sensitivity and specificity, no? When trying to identify occlusion myocardial infarction from your patients with LBBB. Okay. Okay, so this is a 43-year-old male complaining of shortness of breath with chest heaviness. So we can see characteristics of your left bundle branch block. You have your widened QRS. You have your monophasic R wave, no, in your 1 and AVL. But on closer look, no, on closer look, you have concordant ST elevation in your 1 and AVL. So when you zoom in, you have at least 1 millimeter there, no? So sabi, pag concordant, meaning same direction, no? Same direction of your QRS. So this is a positively deflected QRS, positive QRS, and the ST elevation is 1, more than 1, no? Concordant, then this, no? This was, a cath lab was activated and they saw occlusion in the LAD. 70-year-old female complaining of chest heaviness with diaphoresis. Again, we see signs of your LBDB. You have your widened QRS. You have your monophasic R wave with a notching in your lateral leads, 1 AVL. We can also see it slightly in your V6. But although it doesn't look too tall, no, when you break it down, this ST elevation, the concordant ST elevation in your 1 AVL, V2 to V6, no, the ratio is more than 25%. The ST elevation here, comparing to your S wave, no, is more than 25%. And when they directed the patient to the cath lab, there was no LAD proximal occlusion. So this is just to zoom in on that last ECG. We can see that this is the J point, the one from the horizontal line. We count the number of boxes up to the ST, no? So that's around, on the V3, you have 3 small boxes. And then when you measure the S wave going down, that's 10. So the ratio is 0.3, so more than 25%. So this fulfills the second criteria from the Smith's modified. Same here on your V4, no? That's the J point. You count the number of small boxes to your ST segment, and then you divide it with the number of boxes from your S wave. And it's actually 6, no? So that also met the criteria. Okay. 8-year-old male complaining of chest pain. So here we can see, the very discordant ST elevation, but of more than 5 in your V1, V2, V3. Only by eyeballing, you know that there's already 10, at least 10 millimeter na height of your ST elevation. So this fulfills your original Scarbosis criteria. But to make sure, to counter check with your Smith's modified, if you count specifically the numbers and divide it with the S wave, the ST versus S wave, it fulfills the more than 25%. Okay. So the last from the mnemonic, PTSD. P again, posterior MI. Your T is your 3 T wave abnormalities. Your De Winter, Wellens, and your hyperacute. Your S is your Scarbosa or your Smith modified Scarbosa. And then your last is your letter D, diffuse ST depression with ST elevation in your AVR. So the uh, L previously ST elevation in your AVR was thought to have an occlusion in your LMCA. But actually, ST elevation in your AVR reflects more of a subendocardial ischemia, not yet infarct, no, due to mismatch in your oxygen demand supply. So that's why there's a widespread ST depression in all the leads because it indicates more of an ischemia rather than an occlusion. But no, it can also indicate multivessel disease. So recent studies have shown that patients presenting with ST elevation in your AVR, yeah, indicates ischemia and not necessarily occlusion. The ST elevation in the AVR is less than 1 millimeter is okay. Multi-lead ST depression in 1, 2, in your lateral leads, no? And then absence of your ST elevation in other leads. So this is a 69-year-old female presenting with chest heaviness and dyspnea. So you can see now the green box shows a 1.5 millimeter elevation in your AVR. And you can see diffuse ST depressions in your 1, 2, AVL, actually in your 3, 4, and then V4 to V3 to V5, no, actually V6. So very diffuse ST depression in other leads, and then your 1.5 millimeter ST elevation in your AVR, no. So this indicates, no, for a cath lab. Okay. 63-year-old male presenting with chest tightness. You have your green box shows your ST elevation in your AVR, and then your diffuse ST depression, 1, 2, V3 to V6. But but no ST elevation in any other leads, just your AVR with your ST depressions. So there is ongoing ischemia. No? A 55-year-old male coming in for unresponsiveness, no, post V-fib arrest, but had regained ROSC. So green box shows your ST elevation in your AVR, and then you have diffuse, no, ST depression in your V2 to V6. Okay, and then this also shows your ST elevation in your AVR and your diffuse ST depressions, no, 1, V2 to V6. 45-year-old male, a female involved in an NVA, motor vehicular accident complaining of shortness of breath and chest pain. You can see your ST elevation in your AVR and your diffuse ST depressions in your V2 to V6 and 1 to AVL. Okay, so that's the last ECG. So in summary, so as clinicians, we should start veering away from just focusing on the ST segment as the only segment representing the presence of myocardial ischemia or infarction, and not just the ST segment being the indicator for urgent reperfusion or activation of your cath lab. But we should start recognizing STEMI equivalents as well. So recognizing signs of occlusion myocardial infarction versus only the ST elevation will lead to saving more lives, decreasing morbidity and mortality. So remember the mnemonic PTSD. So P is for your posterior MI, T wave abnormalities, which is 3, the winter, Wellens, and hyperacute T waves. Your S is your Scarbosa's criteria or your Smith modified Scarbosa's criteria. And your letter D is your diffuse ST depression with STE and AVR. ECG reading takes time. It takes time and practice because it helps if you see a lot of normal ECGs. So all the normal ECGs, you take a look at it so that the moment that there's something different from the normal, you can spot it, and then that's the time that you um, identify what is this abnormality, no? And always correlate your ECG findings to the patient, no, and how they are clinically presenting. So care of patients come first. Do not hesitate to consult with a cardiologist, no, a specialist, if you are unsure of your findings. So these are my references. So thank you. So I'll stop sharing. So do you guys have any questions? None? Good. So remember, no, for if majority of the participants here are Moonlighters, or even actually if you're into your residency training or your subspecialties, um, read and read ECG because the moment that it's a skill, no, it's a skill. It's not book based. The more that you read, the more that your eyes will be able to identify the subtle changes. Kasi minsan, a 90% occlusion in your coronary angiogram will present as a subtle change in your ECG. So practice, practice. Okay. So no questions? Chat box, none?
We have questions po, Doc.
Okay.
Eto po. How do you differentiate early repolarization from STEMI po?
Okay. So that was mentioned in the lecture, no? So yung early repolarization, so I'll share, no? Just to go back. Where was that? Way back. Kasi actually yung early repolarization, it's always a difficult thing to call, no? Early rep lang ba to or STEMI na siya? Lalo na kung chest pain yung presentation ng patient, pero very young naman siya. Sorry. Malapit na ba? I think malapit na. Yan. Okay. So again, no, your early repolarization is usually diffuse, meaning you will see it in almost all of your ECG leads. And then if nagkataon na regional lang siya, regional meaning that you only see it in your contiguous leads, no, 1 AVL, 2, 3 AVF, or your anterior septal leads, you look at the shape of your ST segment, no. If it's concave, no, smiling siya, that and then you relate clinically, no, then that's most likely an early benign repolarization. But if your slope is concave, paakyat, palubo, no, then that's most likely your myocardial infarction. But remember that your benign early repolarization is common in young patients, no, less than 50 with no comorbidities. It's uncommon in your elderly patients. So kung may nakita kang you have an elderly patient complaining of chest pain, and then the ECG is typical of your early repolarization. Take a second guess, no? Parang don't be too fast on deciding na hindi ano to pa-concave, so early rep lang to. No. Investigate more, no? Kasi it's not common, lalo na your elderly patients are more at risk, no, for your MI. Any more questions?
Ayan. Thank you, Doc. Wala po ba sa audience?
Chat box, I don't think
Wala
so.
po.
Yeah,
Ito na
oo.
lang, Doc. How do we differentiate myocarditis from STEMI?
Okay, so myocarditis is it's myocarditis is caused by an inflammation of the myocardium, no, as compared to your myocardial infarction, which is caused by a clot, no, that is occluding your coronary arteries. Your myocarditis, it presents with on the ECG, it presents commonly as sinus tachycardia, and there is non-specific ST changes. So hindi siya mataas, hindi siya regional. Also, your myocarditis is diffuse, no? It's seen almost in all of your leads kasi nga the whole heart is inflamed, no? But one of the differences is that yung myocarditis, it has your PR depression. No, PR depression, if you search for it, sorry, from the PR segment, no, from the J point, hindi siya agad dumediretso to the ST segment, it goes down first. So yung P wave goes down, tapos tsaka magsa-start yung QRS complex. So that's one of the key characteristics for your myocarditis and pericarditis, no? And usually, ano siya, diffuse, not like your STEMI or ST elevation from OMI na regional.
Ayan. Thank you, Doc. Ito pa po. Meron pa po. When should we request for right-sided chest leads and posterior leads?
Okay, so yung right-sided chest leads, as mentioned before, no, is when we are entertaining um, RV, RVMI. So when you see inferior wall, signs of inferior wall myocardial infarction, meaning meron kang ST elevation sa 2-3 AVF, no? Isipin mo, that's usually associated with right-sided, no? RVMI. So, para ma-check, no, for RVMI, when you see 2-3 AVF, may ST elevation, okay, tingin ka sa V2, V3, V4, usually may reciprocal changes yan. When you say reciprocal changes, you have ST depression also. So may ST elevation ka sa 2-3 AVF. When you look at your anterior leads, V2, V3, V4, usually may ST depression yan. So when you see that, no, you request for your right-sided leads. Right-sided leads means that ita-transfer nila yung lead ng V4, V5, V6 to the right side of the chest, no, to check for RV infarction or yung pag-spread ng infarct to the RV side. For posterior wall, that's different, no? That's the posterior MI. Isa yun sa mga STEMI equivalents, no? That's when we see your ST, horizontal ST depression in your V2, V3, V4 without any ST elevation. So yun yung kapag nilalagay yung V4, V5, V6 leads on the back, on the scapular area.
Alright. Thank you po, Doc. Ito po, last na, Doc. I think this would be the last question. Why is there a move from STEMI to OMI?
So there is a move from STEMI to OMI because when the STEMI paradigm boxes our mentality to just looking at the ST segment to decide if the patient needs urgent reperfusion. So pag may nakita tayong chest pain, okay, chest pain siya, nag-ECG. Parang natitrain tayo to look at the ST segment lang. May elevation ba? Wala. And then tendency is, if we don't see any elevation in your ST segment, parang nada-downplay na natin yung case ni patient, no? Parang iniisip na natin, hindi naman STEMI, so hindi ako nagmamadali. But then, because of that box mentality, they have found through research, no, that patients who do not fit the criteria of ST elevation and underwent angiogram, no, later during their hospital stay, they were found to have occlusion, but they did not fit the criteria for ST elevation. So eventually, they found that there are certain um, ECG criteria na walang ST elevation but have 90 to 99% occlusion. So they want to change the mentality from not ST elevation MI to just thinking occlusion myocardial ischemia, so that we're not boxed into just looking at the ST segment but actually looking at the whole ECG, kasi there are some subtle changes na are equivalent to 99% LAD occlusion on angiogram. So gusto natin mas wide, no? We don't want to miss patients who need urgent reperfusion just because hindi sila nag-fit into the STEMI criteria. So we want to veer away from that, no? And use the occlusion myocardial infarction versus non-occlusive myocardial infarction label.
Ayan, I think that would be all po. Okay. Yan, thank you, Doc
Okay.
Moy, for your very
Thank you. I hope you
informative.
guys learned, no? Kasi this is really a change in the paradigm, no? Not everyone is aware of these changes, no? So thank you, Ma'am Bessa. Thank you,
Thank
everyone.
you po. Thank you, everyone. You can leave the meeting na po.